Okay, so let's get started. Again, I'm assuming everyone can hear me okay. Today's topic is laser therapy for Achilles tendinopathies. And I'm going to really focus more on the most common one, which is tendinosis. I'll also comment and, of course, talk a bit about treating tendonitis as well, because you will see that clinically in practice. As far as tendon ruptures go, I'm not really going to get into that too much because obviously you're looking at more at post-surgical care for something like that, and that would be a very separate webinar indeed. So just so you're aware, these webinars are recorded and edited, and then we tend to send out a link within a few days that that you can rewatch it, or if you need to leave early or what have you, or even in the future, if you register, you can still receive that email, regardless if you tune in or not. So the agenda really is to go over some of the anatomy and histology. It's really important to understand tendinopathies and why they're so challenging to treat. And then specifically Achilles tendinopathies, the etiology and some epidemiology and a bit of the pathophysiology and symptoms. This is probably a review for a lot of folks, but it's always good to have some context as well too. If you have any questions for me during the webinar, please type them into the Q&A box and I'll address those questions at the end. And then I'll specifically talk about eccentric loading exercises. I have a few videos to show everyone. These are really critical when you're treating tendinosis conditions. Many of you are aware of this. It is actually the most evidence-based form of treatment for tendinosis. So if you're not doing them, and if you're not doing them properly, then this deserves a revisit because a lot of the evidence suggests that you should be doing these with your patients. And then, of course, the role of laser therapy and specifically Bioflex and how you would approach treating a tendonitis as opposed to a tendinosis, and then any Q&A at the end. So that's how it's going to roll out. Specifically, if we look at the anatomy, if we look at the sort of histology and the cellular makeup of tendons, we all, of course, know that tendons consist of collagen. They're formed into fibrils within the context of fascicles and the tendon itself. Of course, they're all wrapped by specific sheaths that surround and protect and minimize how much the tendon can actually expand. There's also proteoglycans within the cell as well that give it definition. These have different names, fibromodulin and decorin. So this is basically what it looks like. You can see the little picture, excuse me, of an unloaded versus a loaded tendon, and the collagen, how it has some wave to it or give to it. And of course, it can stretch to some degree, but not a large degree. Now, specifically, when it comes to healing of a tendinopathy, we're most interested in the cells within the tendon itself. And these are referred to as a specific tendon fibroblast, sometimes called a tenocyte or tenocyte. And it's these cells that are very unique in the tendon compared to other fibroblasts within the body. Specifically, these fibroblasts or tenocytes have the ability to communicate with each other through what's called gap junctions. So it's really fascinating that, that because they can communicate, that means that when you impact one cell or a group of cells, it can actually cause an effect in adjacent cells or cells that are communicating, which is really why it's so important both for laser therapy and for eccentric loading exercises, because how it actually works on these cells is not just on one cell or isolated cell. It's going to work on a series of cells that communicate with each other. So mechanical loading, which of course is what a tendon undergoes, this actually stimulates protein synthesis. It does this by tugging at the cytoskeleton, and this sends actually signals to the nucleus. And this causes a release of biochemical signals that eventually lead to increase in gene expression and then to protein expression and translation and production. So when you're doing therapy for tendinopathies and tendinosis, this is a big part of what you're trying to achieve with the patient, is to load these tendons safely but effectively in order to increase the ability of these cells to repair. Definition-wise, it's really important to understand there are major differences between a tendonitis and a tendinosis. And again, I'm assuming everyone here out there knows that, but it's just a good review because maybe you haven't looked at this stuff for a while. So a tendinopathy is just a generalized term for a clinical syndrome of tendons where there's pain, typically some swelling or edema, and some kind of functional impairment. So that's a sort of a generic term for an issue with a tendon. Now, the most common issue with tendons is tendinosis. And this is not what a lot of people think it is. It's not an acute inflammatory or really even an inflammatory process. It's actually considered more of a degenerative, non-inflammatory process, and the collagen becomes quite disorganized within its structure. So you have to treat it quite a bit differently, and the prognosis and expectation for the patient needs to be managed appropriately because it's very much different. When you're tackling a tendinosis, by the time the patient comes in to see you, typically they're well advanced. And if they're well advanced, this is definitely something they need to be aware of because, if they come in and say, hey, I'm starting to get, soreness in my tendon, and they didn't think anything of it before, and now you have to explain to them, well, it's probably been going on for months, if not years. So in order to resolve it or really help it, it's going to take a dedication and a fair amount of time. So that's really important. Whereas tendonitis, of course, is an acute inflammatory. It's a much rarer process. And this is where, like, if someone goes out for a run, they're 100% fine. And of course, they stress the tendon too much and cause some micro tearing or some actual damage, and they get an acute inflammatory process. So it's usually, an overloading, acute overloading that's causing this problem. This you will see, but generally speaking, not as common for sure as a tendinosis or degenerative type of scenario. Tendonitis will heal much faster, given the nature of the condition compared to tendinosis. Now we're dealing with a tendon. We need to understand anatomically there's a mid-substance portion as well as the insertional portion at the calcaneus. So these issues can occur anywhere along the tendon. Oftentimes it's mid-substance, so we need to accurately treat that area. But of course, it can also occur at the insertional point as well. So the Achilles tendon pathology in general is estimated to be responsible for as much as 50% of all sports-related injuries. So you can imagine if you're dealing with any kind of sport, soccer, baseball, anything where it's explosive and you're running, jumping, which, most sports, right? You're going to come across these issues. And especially if the athlete is getting up there in age, 30, 40, 50, 60, that's where you're seeing a lot of the tendinosis. And of course, acute injuries occur in soccer players, runners, that kind of thing, where they overdo it, that kind of thing. Now, 70% of it ruptures, they occur in elderly, I say elderly, middle-aged or older patients, 30, that's not elderly, but it's getting up there and older, right? 40 and 50 plus. And usually it's occurring while they're playing a sport, squash, tennis, even golf or what have you. This is where you're seeing these ruptures occur. And I tell you, we've seen a lot of patients with ruptures, especially CrossFit, where I don't know if you're familiar with CrossFit or you do it yourself, you know that there's a lot of jumping involved, explosive jumping. Not a big fan if you're in that age bracket, because if you have any sign of tendinosis, you're a prime candidate for having a rupture. So yeah, you might want to be pretty careful about that. Age is commonly associated with increased prevalence of degenerative changes, as I mentioned, because there's decreased cellularity, so decreased fibroblasts and ability to repair. Also, there starts to become increased glycosaminoglycan content, which lends itself to less resilience, less tensile strength of the tendon itself, and a lack of the collagen fibril organization. So this is all what's occurring as you get a little bit older. I have a little graphic on this to show you. So as you get older, the tendons, not just Achilles, but all tendons, start to lose their elastic properties. This causes the muscles to actually have to work more, and then you start to see these slow degenerative changes in the tendon. Symptoms, now more so with tendinosis, not so much tendinitis, because I think tendinitis is pretty clear. You're going to have redness and acute swelling and acute pain. But in tendinosis, it's more intermittent pain. It tends to be more related to the exercise or activity that they're doing. A lot of stiffness, that's one of the key hallmark features of it, typically upon weight bearing after prolonged immobility. So whether they've just woken up in the morning and they feel that stiffness, or they've been sitting all day in the office in a chair or watching a movie, go to stand and they can feel it. The complaint is usually stiffness. And then of course they have more of this and pain at the commencement or beginning of the exercise, and it starts to lessen as things loosen up and get some circulation going. However, as a condition actually worsens, there's a progression from pain that's felt towards the end of the exercise session, as well as pain throughout the activity. So you'll start to see these people complain, or these patients complain of pain, not just at the beginning, but it's prolonged. And that's a big warning sign that they need to be carefully monitored and looked after. With respect to pathophysiology, there's intrinsic and extrinsic risk factors. Intrinsic, obviously I've mentioned a few: age, males dominant over females. That could be because of activity or more in athletes. The body weight, more common in larger framed people. Tendon temperature, systemic disorders. There's a series of them, including genetic predisposition, as well as blood supply. Extrinsically, we're looking at other factors, specifically certain types of drugs. Prescription drugs can have an effect as well, and overuse of the tendon. Sorry about that, just have a bit of a tickle. So intrinsic factors include things like abnormal dorsiflexion or subtalar range of motion. It can be either decreased or increased. So you need to look at the mechanics of the ankle complex and make sure that you're treating that as well. Increased pronation, which is of course extremely common in the general public. This can cause what's referred to as a whipping effect on the Achilles tendon. This can lead to decreased blood flow and over time issues with the Achilles tendon. The structure itself, there may be abnormal ultrasound signal. This may proceed with pain production. So there's issues with the tendon structure. And other comorbidities, I mentioned like obesity, hypocholesterolemia, even high blood pressure and diabetes. These all seem to be comorbidities with an increased frequency of Achilles tendinopathies. Extrinsically, one of the biggest issues is training errors, especially for people that are weekend warriors or don't have proper coaches. So sudden increase in mileage, increasing intensity in hill training, going from a layoff in winter to all of a sudden going full tilt in the spring, those kinds of things, lack of recovery time. We all know these things. That's where, you also can give advice to your patients as well when they return to the sport, and how to do that appropriately. I mentioned certain drugs, certain antibiotics can also be a factor as well. Microscopically, tendinosis has a high percentage of immature type 3 collagen fibers. I'll show a little picture of this coming up. There's increased ground substance. That's a glycosaminoglycan within the cell. And the vascularization is sort of all over the place. It's not sort of specific to where the typical tendon microvascularity should be. There's also a decrease or loss of collagen continuity, such that the collagen fibers, instead of running parallel, sometimes they fail to link. They start to reduce the ability to facilitate load bearing. So basically it becomes weaker because of poor alignment of the collagen fibers. And that's again where eccentric loading exercises are really critical. So chronic tendon injuries, again, are degenerative in nature and not inflammatory in nature. Oftentimes these are misdiagnosed or treated inappropriately with NSAIDs or injections, those kinds of things. But actually the research indicates that this type of medication or intervention can actually make that tendon more susceptible to further injury and damage, and eventually longer recovery time, and actually can increase the likelihood of rupture. And we all know this of people that have had ruptures mainly because they're on corticosteroids, especially for treatment of RA or other issues as well too. So one has to be extremely careful with that as well. Pathophysiology wise, when you look at a normal tendon, the collagen is nice and parallel. Type 1 mature collagen, you see the haphazard spider's web, a lot of gaps, cellularity with respect to immature fibroblasts and immature collagen fibers. So that's what the tendinosis looks like. If you look at it graphically, you can see a normal tendon where it has the fibers sort of wave-like parallel in fashion, a certain amount of protoglycan and these fibroblasts or tenocytes. And then as the tendon slowly ages, you'll start to see changes. You'll start to see reduction in the protoglycan. You'll start to see changes in the tenocytes as well. Even the collagen appears a little bit different. But as you get into tendinopathy, that's where you start to see the fibrils of the collagen making sort of more haphazard, more type 3 increase in the matrix and protoglycans and the swelling, poor cellularity as well. So this is where the tendon becomes quite weak. With respect to overcoming these types of issues, a tendinosis from time to recovery to early presentation is 6 to 10 weeks. A tendonitis can be usually up to a few weeks, couple of weeks. For a chronic presentation of tendinosis, and typically that's what we see in the clinic, you're looking at months, 3, 4, 5, 6. You even see it longer. And this is because people come in when it's quite chronic, quite swollen for years. Tendonitis, usually get to it pretty quickly, but if it's kind of recurring and they're getting these tendonitis because not letting it heal, that kind of thing, it can take several more weeks to have a complete recovery. But typically you're going to see it recover in a month or so, whereas tendinosis, you're looking at multiple months. And that's really important to understand. It's also important to understand that there's lots of other things that can go on around the Achilles, differential diagnosing wise, and it might be multiple issues as well. Everything from retrocalcaneal bursitis or bursitis in general. There can be tendonitis right at the insertion point. There can be inflammation of the synovial sheath. So lots of different issues going on there. So pay attention to that, maybe get some imaging and treat that appropriately as well. So let's talk a bit about eccentric loading exercises. These are heavy load exercises, and they're meant to increase the tensile strength of the tendon. This through communication and activation of tenocytes. It can increase the amount of type 1 collagen, decrease the amount of this ground substance that causes the sort of the swelling and the weakness, and therefore it reduces the tendon volume and eventually helps to restore the tendon to more normal or healthy state. I'm not certainly guaranteeing that it's going to go back to normal healthy, because it's a real challenge to get them back to looking pre-tendinosis. Tendon healing obviously is a continuous process. Again, because you want tension across these fibroblasts, and this will cause these cells to actually divide, multiply, and also align along the perpendicular line of the stretch that you're doing with your patient. This is analogous to Wolff's law, where that tension on maturing granulation tissue leads to the development of preferential direction of the collagen fibers. So this is really important when you're treating these patients. Little video. I don't know if I'll have time to show all of it, but I will show some of it. These are just eccentric loading exercises. This is the first type of exercise where the knee is straight or extended, and the patient is lowering down on their tendon. It's not uncommon that you could have the patient increase the weight by wearing a weighted backpack as well. Let's take a look at the next one.
After completing the first exercise, you should then complete the second exercise. The second exercise is very similar to the first, except that the knee of the injured leg remains bent. you will be standing with all of your body weight on the injured leg. However, the injured leg will need to be flexed at the knee. From an upright position and standing with all of your body weight on your injured leg, you then lower the heel of the injured leg beneath the step.
So you can see the two differences. One's extended knee and one was a bent knee that you maintain as you do the similar exercise.
Tendon and muscle soreness following the exercises during the first 4 weeks is expected.
So it's important to communicate with your patient that this is not a fun exercise. It hurts. So it's to be expected. So patients oftentimes won't be doing their exercises because it's sore. It's really important to maybe do them while they're in your office. So the setup is really easy to do. Some people are really motivated and they'll do it. Others will need some supervision. So, and also just reassurance while they're doing the exercises. The video also mentions about, you can also apply some ice a little bit as well too, after completion of the exercise. So with respect to laser therapy, it does a lot of things potentially for Achilles tendinopathies. It can improve collagen fiber organization, help with parallel alignment. It can help increase or stimulate fibroblasts to secrete and mature type 1 collagen. It can down-regulate something called MMPs or matrix metalloproteinases. These degrade the matrix as well. So MMP is something that's measured all the time in experiments. The higher the MMP, what you don't want high MMP. So it's known that laser therapy actually lowers that and down-regulates it. It can overall reduce fibrosing, and it can cause short spikes of ROS, which are reactive oxygen species. These ROS can increase cell signaling, regulation of the cell cycle, in other words, increase mitotic index, and essentially help the cell turn over, undergo synthesis, and function more normally. Okay, so not a lot of time left, so let's get into treatment, right? That's why probably a lot of you are here. We do have a tendinosis protocol. Maybe a lot of you aren't aware of it. And Dr. Khan put this in specifically understanding that it's not an inflammatory process when you're dealing with tendinosis. In general, you can see that the first stage has a pulse to the red, 50-50, 50 flashes per second and 50% duty cycle. So it's a little bit lower on the red. The tendons are thick structures, and usually with the tendinosis, there's a lot of swelling and thickness here. So you can see that's reflected in the duration of the infrared, starting off with 10 hertz per cycles per second and a low 20% duty cycle, and ranging up to 60. You can customize that in as a patient starts to plateau, and using maybe about 5 minutes or so of 100% power continuous wave of the infrared laser probe. When you get into stage 2, you can start to see a bit more modulation of the red, and a little bit higher duty cycle, getting up to 50 to 90. And again, same thing, slight increase in frequency or pulses per second for infrared, and gearing up the duty cycle. Remember, as you increase duty cycle, increase the total energy density or the actual dosaging. So that's important to remember as well. And similarly, same with the infrared probe, using the same as stage 1. And then lastly, once you get to stage 3, you can see a much higher frequency in both the red and infrared as well. And usually you're maxed out or getting close to maxed out on duty cycle, because you're basically at the most amount of energy, so dosaging, and getting up there in most amount of stimulation with frequency as well. A tendonitis condition, again, you can use a 50-50, or typically you're going to use a continuous wave. You can see that it's a slightly higher duty cycle, 1030 as opposed to 1020. So that's one of the main differences. But also you can see the treatment time as well, a little bit lower, 6 minutes. Now, as far as the placements going, and go over that, because it's not necessarily just one placement, it may be 2 or 3 as well. Laser probe is very similar, and you can see the progression as we get into stage 2 little bit higher duty cycles, higher frequencies, and then eventually stage 3, pretty similar to the tendinosis protocol as well. Placement wise, really, this is something that you will determine based on the location. So if it's an insertional type of issue, you're going to make sure you wrap it around at the insertion. Typically, you'll want to do at least one other placement, so just a little bit higher up, more at the mid belly. But if the actual issue is in the mid substance, then the first placement will be this middle one. And then the second placement, I usually do at the musculotendinous junction, but you may want to do 3. You may want to do at the insertion, at the mid substance, and at the musculotendinous junction. So palpate, observe, see where the issues are. Minimally do 2, I would say, and you might need to do 3. If there's something like plantar fasciitis with it that's also occurring at the same time, you also have to treat the plantar aspect of the foot using the plantar fasciitis protocol as well. If there's bursitis or other issues, generally speaking, you're going to treat pretty similarly. Just make sure when you use a probe, you also want to focus on that secondary pathology as well. Specifically, when we're using the probe, I'm going to suggest that you treat the actual most posterior aspect of the tendon, as well as the lateral and the medial side of the tendon. So let's say we're treating this one spot here. You're going to treat directly on the posterior aspect, and then at that same distance from the insertion on the medial and lateral side, and then you're going to do that all the way from the musculotendinous junction all the way to the insertion, with a focus and more time spent on the area where the main problem is. And typically that's going to be mid-substance, but it could be also insertional, or if you have other things that going on like bursitis, then spend a bit more of time treating that area as well. Don't forget to maintain firm contact. If there's a fair amount of swelling, you can push in a little bit as much as you can. Of course, a tendon is usually pretty dense, so it's not like you can push it into the tendon itself very much, but it's important to make firm contact so that the light can penetrate as deeply as possible. Treatment plan wise, if you're looking at a tendonitis, an acute scenario, that's where we do recommend the patient be treated every day, minimally 3 times, if not 5 times in that first week. And then you can start to go every alternating days, or maybe 3 times a week. Usually tendonitis, we have very good success. You're looking at 8 to 12 sessions, depending on the severity of it. And the fact that the patient is laying off their exercise or giving it some rest, but you may need a few more depending on the actual severity. Whereas a tendinosis, you don't have to start every day. I mean, you can, and there's nothing wrong with that, but because it's more chronic, alternating days is fine to start off with. And then you're gonna have to continue with alternating days, so 3 times a week, preferably for multiple weeks. 3, 4, 5, 6 weeks. This is a long haul treatment plan, maybe 16, 24 plus sessions. So the patient needs to be patient. You also start to need to integrate eccentric loading exercises as well. Tricky condition to get better. You can really be helpful, and you can look at the mechanics and treat the foot and the ankle complex appropriately as well. But don't forget about the eccentric loading exercises. Okay, so as far as the webinar, that's it. Don't forget that I always do a live online training, basic certification training. The next one is August the 20th. They're usually a full day event. That's a Friday, as well as we have some dates in September and October. We'll be starting to do some live events as well too, knock on wood. We're thinking in the fall time, maybe out west, so to do some in Toronto as well. And also we do advanced training. The next one is cervical spine. We have some great guest speakers, Dr. Ben Ewan from out in Halifax. He'll be doing some lecturing, as well as Slava Kim, our clinical director, and Nathan Chung. So the topics are everything from arthritis and degenerative conditions to post-concussion syndrome. It should be really good. I'll be doing a little talk as well. So it's a 4-hour event. You can sign up for it and go to our website. There's an early bird going on right now, so you should take advantage of that if at all possible. Again, as usual, I really thank you for joining me today. I will be setting up another series of webinars very shortly, so you can go to the website and look for that.